Okay, this morning I'll be taking practice question 4B from April 2023 recall. The question goes thus. Okay. A 65-year-old man who weighs 97 kg is a previous football player who damaged the right anterior cruciate ligament and has been staying alone after his wife died 5 years ago. Is a non-hypertensive, newly diagnosed with diabetic mellitus. He smokes 20 cigarettes a day and takes about 28 units of alcohol per week. He presents with left knee pain, worse when ascending and descending the stairs. So what are the questions there? What are the differential diagnoses in this patient? How will you investigate? The X-ray of the knee suggests subchondral sclerosis. What are other findings? What is the final diagnosis? What are the risk factors in this patient? List 4 classes of drugs in the management. So what are differential diagnoses? So my first differential in this patient is osteoarthritis. He has left knee pain that worsens on ascending and descending the stairs. Other differentials can be septic arthritis. Just that in this patient, it didn't tell us whether the knee was swollen or not. In septic arthritis, the knees can be swollen and really, really painful. Then you can also have the crystalline arthropathies, that's the gout and pseudo gout. In gout, there will be deposition of monosodium urate crystals in the joint, and there can be affected swelling of the joint. It can be as a monoarthropathy, but at times it can actually affect multiple joints. We also have pseudo gout, in which there's deposition of calcium pyrophosphate in the joint and the articular space of the joint. Then we also have rheumatoid arthritis, although most times it affects multiple joints. That means it affects both knees at the same time. Other differences can be psoriatic arthritis, erosive arthritis, reactive arthritis, just as listed in the slide. You can also have a patellofemoral syndrome, in which there will be imbalance in the anterior movements of the knee joint, and patient can present with that and they can have pain. You can also have a prepatellar bursitis, where the bursa between the patella and the patellar tendon is inflamed, and it's otherwise called housemaid knee, Kohlmann's knee, or carpet knee. Also, in people that have neuropathic arthropathy, which is called Charcot joint, maybe from diabetic mellitus, syphilis, or leprosy, you can also present with something that looks like an osteoarthritis, and it's a good differential in this patient. So how will you investigate? In this particular patient, if we take note, it says there was a damage to the anterior cruciate ligament in the right knee. However, where he has pain now is in the left knee. So I think an X-ray of both knees will be good for this patient, because previous injuries or microtrauma to the knee joint over time can progress and also be a secondary form of osteoarthritis. So I want to do X-ray of both knees, and classical things we say, as we all know, there is an acronym that's LOSS. This is loss of joint space, osteophyte, subchondral sclerosis, and some further bone destruction. Also, a CT or MRI can be done. However, it is not something that is done every time, except if you want to visualize the joint space better. Maybe you want to look at the meniscus, the tendon, or if there's any other thing ongoing in the knee joint. There can arthrocentesis of the knee can also be done, which can also be a diagnostic or a therapeutic investigation for the knee joint, in which you take the synovial fluid and you do an analysis of it. In osteoarthritis, most times there may not be evidence of inflammation on analysis. That means WBC may be low, and other things that you are looking for also may be low compared to septic arthritis, where WBC can be as high as greater than 25,000 to almost or thereabout. Then if you look at the synovial fluid under polarized light, if you want to look at gout and settle gout, for gout you might see a negative by Ferrigens under the polarized light, while for pseudo gout we see a positive one. Then you can also do an ultrasound. Ultrasound is said to be important in cases where the anatomy of the joint is actually difficult to assess, especially when you want to do arthrocentesis in this patient. Also, it can be used to monitor cartilage destruction and the effects of the therapeutic intervention in this patient. Then we can also do other auxiliary tests like blood count, ESR, CRP, which can be increased in rheumatoid arthritis and other things, but ESR and CRP are not increased in osteoarthritis. Also, serum uric acid has been said to be good in patients that have greater than 6.8 milligram per dl in their uric acid level. It has been said to actually be a indicator to the progression and increased risk of osteoarthritis compared to people that have less than 6.8 milligram per dl. This was the study done by Krestowski et al. Then, if there is failure of medical treatment, you can do an arthroscopy. You can also do Anna Hanker CRP and CCP, F4P. Looking at the comorbidities these patients have. All these other tests will also come into play to be able to give an holistic care to the patient. So what's my final diagnosis? These patients have less knee osteoarthritis, but it's likely that even in the right knee that there's something going on because it may have a form of secondary osteoarthritis there. What are the risk factors? Obesity. Obesity has been said to be a major risk factor for patients with osteoarthritis because, of course, the weight bearing that the knee or the hip may undergo. But in this particular patient is the weight bearing. There can also be effects of underlying chronic inflammation, which will also worsen the arthritis. Then apart from that, the muscular destruction that can also affect the joint space in patients that are obese. Then older age is a risk factor for primary osteoarthritis, and it has been documented in the literature. Also, trauma and repeated trauma. For this patient, the trauma was on the right knee, but because it's a footballer in the past, there will have been repeated stress on the knee joint and also other joints in the body. So trauma, repeated trauma, microtraumas are risk factors in this patient. He has diabetic mellitus, which is something to be considered as a risk factor in this patient. Smoking, literature shows that smoking is protective. However, it is still dicey. So also alcohol. Alcohol is said to be, there was nothing conclusive from the literatures I check about alcohol and osteoarthritis, but I think in this patient is a risk factor because we have to consider all other comorbidities. Then in this patient, we have to take into consideration that he has social issues, is a widower, he lives alone. So definitely, maybe this is the kind of lifestyle that makes him develop to start smoking, taking alcohol, and then that will worsen his state. So all this must be put into consideration during his management. Okay, sorry. Okay, so what are the class of drug use in management? According to the American College of Rheumatology and the Arthritis Foundation recommended drugs include analgesic acetaminophen, which is usually used when there is just mild to moderate pain with little or no inflammation. Then NSAID can be used, especially when inflammation is present. Opioids. So the way the drugs are given is given in a gradual manner, depending on the pain and the outpatient presents to us. We can use opioids, capsaicin cream. Then we can also use intraarticular steroids, which can be therapeutic for the patient. Then vasosupplementation by giving hyaluronic acid, which is a component of the joint space. We can also give platelet-rich plasma, in which the plasma is between 150,000 and 350,000 for this patient, which has been said to actually improve and relieve symptoms in this patient. Then there is also pyelotherapy that can be given to this patient. Okay, so that's the end of the main presentation. I don't know if I can just go ahead and give an overview, Dr. Okele.
Okay, 2 minutes. Go ahead.
Okay, it's just be an overview. Okay, under this outline. Okay, so osteoarthritis is a chronic disability seen in older adults, and it affects about 30 million individuals in the USA. In Nigeria, we don't have the exact literature or data, but this is a study in Nigeria by Archipelago et al., which says that it's higher in females. So osteoarthritis goes beyond the knee itself. It's actually about the entire joint organ, including the subcranial bone and the synovium. Okay, let me skip this. Okay, so there are two types, the primary OA and secondary OA. For the primary OA is occurs in previously intact joints that have no apparent initiating factor and is commonly seen in older individuals. For the secondary OA, most likely maybe there is an insult in the past, maybe micro trauma, or patients have rheumatoid arthritis or have aligned joints, all these verum vagos and the others. So it occurs in relatively younger individuals. So what are the risk factors? These are just some additional risk factors from what I've mentioned earlier. I think people will see it from the slide. So going to the pathophysiology itself, which is important that we try to revise. In the past, it has been said that it's a degenerative disease. However, apart from degeneration, there is also effects of inflammation and then the abnormal mechanism in the joint movement. So there is inflammation that occurs when cytokines and metalloproteinases are released into the joints. And what does this one do? They cause degradation of the articular cartilage. If this progresses over time, they actually destroy the chondrocyte that is supposed to produce proteoglycans that actually help in repair of the joint cartilage. So over time, there is an imbalance in the proteoglycans production and the chondrocyte, because the chondrocyte are the cells that produce proteoglycans are going down. So this leads to reduced synovial fluid in the joint space, causing to more wear and tear. This leads to more damage in the joint space, exposure of the subchondral bone, cystic degeneration in the bones, osteophyte and joint mice in the intra-articular cartilage, and then progressive joint destruction if no intervention is sought after. And this is an algorithm just trying to describe what I've said, but because of time, I will just move on. Symptoms, we know the symptoms already: reduced range of motion and crepitus, joint dwelling that actually is less than 30 minutes. If it's in rheumatoid arthritis, it's more than 30 minutes, there can be swelling, and then there can be pain or movement of the joint. Okay, so what are the investigations? I think I've mentioned this earlier, so I'll skip this slide. So what are the goals of management? For this particular patient, it's a multidisciplinary approach. You need the rheumatologist, you need the dietitian, physiotherapist, you need the endocrinologist, occupational therapist in this patient, and most likely maybe a social health worker too, because it stays alone. But the main goals of management are to relieve pain and to improve functional status of the patient, and they can be under non-pharmacological, pharmacological, and surgical. So patient education, you need to let them know about the disease. Apart from that, you need to talk to them about their footwears. Apart from that, they can also talk to them about offloading of the knee joint, then eat and cold compression, weight loss. This man is obese, so weight loss is very important. Exercise actually has been said in literature to improve osteoarthritis, but because of the pain at times, patients don't want to move around. So there must be graded exercise, maybe home-based exercise by a physiotherapist that will be able to help the patient. They've also talked about Tai Chi yoga to actually be effective in the management of osteoarthritis. Then there are muscle training, occupational therapy, unloading of joints. Then they have talked about post-electromagnetic fluid stimulation. So pharmacological, the things I've mentioned earlier. Additionally, a muscle relaxant that can be used for the patient, which relieves pain. And then nutraceuticals. Surgical, we can have arthroscopy, osteotomy, arthroplasty. And then finally, fusion. Fusion is when there is a failure of arthroplasty, and then you have to fuse the new joints together. It actually relieves pain, but over time, the friction in between the joints makes the intervention not to be a good option for such patient. Then prognosis depends on the disease and number of joints affected. So older age, higher BMI, aligned joints initially, the multiple involved joints in osteoarthritis, all those ones are poor prognostic factors. The newer trends, they've talked about novel biomarkers that can actually help us prognosticate in people with osteoarthritis. And I mentioned the uric acid earlier. They've also talked about genetics because they found out that some genes are actually involved in osteoarthritis, and this includes Adam's gene, Pol 11, 17, and some other genes. But I'll add them to the slides later. But in this genetic involvement, they have not actually give anything that is substantial about it, but it's looked at that in the nearest future, maybe there will be genetic treatment for the management of osteoarthritis, then stem cell therapy, metalloproteinases inhibitors, MIV-711, and monoclonal antibodies. All these ones are other clinical trial currently. These are some of my references. Thank you for your attention.
Thank you so much, Dr. Timi, for that beautiful presentation. Okay, so now we take comments and questions first from the participants. Okay, and then let's keep the thanks coming on the chat. Okay, I can't see any hands up yet. Okay, please let me start with let me ask this question. Please, what's prolotherapy? You mentioned it in one of your slides. That's my question. And then to add to the non-pharmacological, I don't know whether you, just a little add-on, whether you mentioned all the assistive devices like knee braces, knee sleeves, I mean, during the main presentation, even aquatic exercises.
Thank you very much, ma'am.
Then did you mention COX-2 inhibitors for patients with PUD? I mean, not for the question, I mean for the main presentation. Just an add-on.
Okay. Thank you very much, ma'am. I mentioned prolotherapy. What is done here is that a small volume of, because of the pain felt at the joint spaces, so a small volume of irritant is actually injected into the new joint or the affected joint. And this sort of reduces the pain, but it's temporary. But because of the temporary effect, so they now have specific weeks in which they inject the joint. So they use that first week, 5 weeks, 9 weeks. If there is no resolution of, if there is no significant resolution of symptoms, then they proceed to 13 and 17 weeks. But we must remember that all these are done with the non-pharmacological therapy, which is actually the main treatment for osteoarthritis, because it has been said to improve the pain and prognosis in this patient. So you are very correct, Ma. Apart from the footwears that I talked about and the offloading using walking aids, aquatic exercises, knee braces, their joint protective techniques exercises are things that actually help in osteoarthritis. Thank you very much, ma'am.
Oh, yeah, thank you so much. I even saw somewhere acupuncture also.
Yes, acupuncture, TENS, Tai Chi, yoga. There are many non-pharmacological interventions that have been said to be of good prognostic factors in this patient. Sorry, I'll add them to the slide.
Well, thank you so much. Okay, so there's a lot of thanks to you, Dr. Temi, on the chats from Dr. Florence. Dr. Anthony says thank you, Dr. Lighton, Dr. Owal Shuaibu, Dr. Rita Lako, Dr. Regina Wiki, Dr. Mustafa, Dr. Musa Joseph, Dr. Blessing Azuko Yamadi, Dr. Olalikan, Dr. Raga, Dr. Timi Tope, and then Dr. Mamodo is saying thanks. GI80 GATE is a landmark study. Chief, maybe you tell us more about that data. Then Dr. Lawrence says, thank you for the presentation. What is the role of chondroitin sulfate you mentioned under pharmacologic therapy?
Okay, thank you very much for that question. Thank you, Dr. Ekele. For chondroitin sulfate is a glycosaminoglycan that is part of the normal structure of the joint organ. So when there is osteoarthritis, all these things are reduced in the joint spaces, even with the proteoglycans. So the role is to actually, sometimes they inject it back into the joint. Like there is a deficiency of a particular thing in that joint. So they try to inject it back to see the effect, whether there is improvement. So it's like a replacement of what is lost in the joint space, at least from what I came across. Thank you.
Thank you so much. And then Dr. Olaiton Abimbola is saying you talked about footwears. Please expatiate.
Okay, thank you very much, Dr. Olaiton, for the question. Like I said earlier, what actually benefits patients with osteoarthritis is actually the non-pharmacological management. So for footwears in osteoarthritis, they've talked about the instep, and the outstep, but we will wait for the rheumatologist here to actually shed more light. So there is a way that the mechanism of the joint when you're walking actually take back the stress, depending on your footwear, to the joints that are weight bearing. That's the knee joints and the hip joints. For example, ladies that wear heels, there will be an imbalance in the lateral and the medial spaces of the knee joint and the hip joint because there is a distortion in the natural placement of the joint. So when you talk about footwear, sometimes if you discover that, oh, is the anterior cruciate ligament or there is an imbalance in the medial femoral part of the knee joint, affected knee joint, or both knee joints, you might want to give special footwears to some patients. But you start from soft footwears that actually absorb the stress of walking. Then at times you might need to increase the lateral part of some shoes so that there will be a balance in the joint spaces. But I will wait for our chiefs in rheumatology to actually shed more light on this. But that was my understanding. Thank you.
Oh, thank you so much. Okay, so all right, so Dr. Olajumoke is also asking about the prolotherapy. I think she has mentioned it. If I got it right, she said she injects irritants into the joint space, Abby?
Yes, please, that's it.
All right, thank you so much. Dr. Justice is saying thank you. And then Dr. Yahaya is saying thank you for the good presentation. Please, can surgery play a role in the management of osteoarthritis?
Thank you very much, Ma. Thank you, Dr. Yahaya, for the question. Yes, in the failure of medical therapy, you go ahead and do surgical intervention, and this includes osteotomy, arthroplasty, fusion. I think there is a slide on that. For osteotomy, if there is a malaligned joint, like this varum or valgus or neuropathic joint, you just create a hole to create a balance in the joint. Then for arthroplasty, there's replacement of the joint in which you might need to put a prosthesis there. And then for fusion, when there is failure of arthroplasty, so you want to fuse both joints together. And when you fuse it together, you want to reduce the friction in between the joints. Yes, it relieves pain, but because of excessive stress, and if you don't manage the other comorbidities, if the person is overweight, this also does not give a good prognosis in the long term. So surgical intervention is indicated if there is failure of pharmacologic and non-pharmacologic therapy. Thank you.
Thank you so much. Thank you so much, Dr. Timi, for the beautiful presentations, and thank you those who have questions. Okay, so now I'll hand over to our teachers. Mark Christabel.
Okay, thank you so much, Dr. Adeaju. Thank you, Dr. Kele. You did quite well. I don't know if our teachers, Chief Cookie, Nancy, Chitro, Remingos, Fatima, Dahatu, Ajibola, Okopi. I don't know if you, Dr. Success. Yes. I don't know if any of you have any comments.
Dr. Christopher,
Yes,
good
sir.
morning. I think Dr. Ade did beautifully well, and all the contributions too were on point.
Yeah, I think so too. It was quite a wonderful presentation, quite detailed, seemed to understand the topic itself. So, Dr. Adeaju, thank you so much. Thank you so much. We want to appeal that going forward, let's be hearing your voice more. What's your specialty, please?
Thank you very much, ma'am. Cardiology, ma'am.
Okay, please, let's be hearing your voice more, please. Such a nice voice, please. Let's hear it more often, please. Thank you, one,
Yes,
for this
Chairman.
wonderful. Thank you for this wonderful presentation, quite detailed. Thank you so much. Dr. Kale, over to you. Can comment the second presentation.
All right, thank you so much, Ma. Okay, please,
Yeah.
Dr. Yin Egwim, please share your slide.
Okay, thank you. Good morning. Thank you. Can you see my slide?
I can see it. Thank you so much. Okay, so you can go ahead.
Okay,
You have 10
thank
minutes.
Okay, good morning, teachers. Good morning, everyone around. Today I'll be presenting practice question 5B. The question is: a female patient with rheumatoid arthritis who has been on methotrexate and other medication has received 2 previous doses of rituximab, and the patient develops itching and swelling of the lips, and also had a blood pressure of 80/60 millimeters of mercury. Question A: what is the diagnosis? B: what is the mechanism by which rituximab is causing these current symptoms? C: list other clinical features of this condition. D: how will you manage this condition? E: how will you prevent a recurrence? The diagnosis is the patient has a drug-induced anaphylaxis presenting an anaphylactic shock. So the diagnosis for this patient is anaphylaxis. What is the mechanism by which rituximab is causing these symptoms? Excuse me. Rituximab can cause anaphylaxis through several mechanisms, and the mechanisms include: 1, it can cause it through an IgE-mediated reaction, which leads to release of histamine and other inflammatory mediators from mast cells and basophils, and resulting in the symptoms the patient is having, like itching, swelling, and hypotension. Also, it can also cause it through the cytokine release syndrome, where rituximab triggers the release of cytokines from activated immune cells. And also, it can cause anaphylaxis through complement activation. As we all know, rituximab binds to CD20 B cells, and it will activate complement system, leading to anaphylaxis. List other clinical features of this condition. Other clinical features could include respiratory system. Patient can have throat tightness, shortness of breath, cough. Cardiovascular, patient can have dizziness, weakness, syncope. Gastrointestinal system, patient can have dysphagia, vomiting, and diarrhea. And neurologic system is actually a very rare system that occurs, where patient can present with headache, dizziness, can also have seizures. The common systems that are respiratory, cardiovascular, and GIT. How will you manage these patients? Anaphylaxis is a clinical diagnosis, so no lab studies will be required for this patient, and is a medical emergency. I want to admit this patient into the emergency unit. And the cornerstone of management for this patient is I want to call for help for resuscitation team to join me managing this patient. I want to focus on the patient's airway, breathing, and circulation. I also want to stop the rituximab medication that the patient is receiving. And at the earliest opportunity, I want to give IM epinephrine. For the airway management, I want to maintain this patient's airway. I also want to place the patient in supine position and have the legs elevated. I'll commence patient on supplemental oxygen using a non-rebreather max at a flow of 15 liters per minute of high flow oxygen. If the patient has respiratory distress following airway compromise from maybe the swelling of the tongue, I want to intubate this patient on an emergency basis. However, if intubation is difficult because there is increased airway edema and doesn't allow orotracheal intubation, I want to invite the ENT and also who will help perform an emergency cricothyroidectomy for this patient. Epinephrine is the first and most important treatment. I want to administer epinephrine, and the IM intramuscular route is preferable. IM injection, the IM epinephrine I want to use is the 1 in 1,000 dilution, which usually comes in a 1 milligram meal. I'll use a one meal syringe to take about 0.5 mils of epinephrine. If patient is less than 50 kg, I want to give 0.3, but if patient is more than 50 kg, I want to give a 0.5 milligram IM. I'll give it in the mid-outer thigh. I will reassess this patient every 1 minute to 5 minutes. And if patient is still not responding, that is, still has hypotension, I want to repeat epinephrine, followed for about 2 to 3 doses. It's expected that by the second dose to third dose, patients would have started feeling better, and hypotension, patient would have, the blood pressure would have appreciated. However, if after the second to third dose and patient is still having hypotension, I want to prepare an IV epinephrine infusion to administer to this patient. IV access is going to be obtained and a high bore cannula is preferable. I'll commence fluid resuscitation, preferably normal saline for this patient. And, excuse me, sorry. I want to commence fluid resuscitation for this patient. A preferable fluid is normal saline. I want to give about 1 to 2 liters of fluid within the first minute. So I want to rush the IV fluid. However, if after the first 2 liters of normal saline, patient's blood pressure has still not appreciated, still hypotension, I will still want to recommend IV fluid. IV fluid can be given up to 7 liters as required, but it's important to check out the cardiovascular status of the patient and know if patient is at risk of pulmonary edema, has any cardiovascular risk factors, and fluid giving will be I'll be cautious with giving fluid. I want to continue non-invasive hemodynamic monitoring for this patient. I want to check the pulse oximeter and know the oxygen saturation and also the urine output for this patient. If patient, however, still has protracted hypotension following epinephrine that has been given a normal saline, and patient still has hypotension, I want to monitor this patient in an ICU setting. Other vasopressors can also be used to support the blood pressure if patient still has hypotension despite epinephrine and normal saline. Other vasopressors that can be used could be vasopressin or dopamine. Adjunctive agents can also be used. H1 antihistamine and H2 antihistamine is preferably to be combined. It's going to help relieve itching and hives. Cetirizine, diphenhydramine can also be used. I want to commence this patient on bronchodilators if patient has bronchospasms that are not responsive to epinephrine. Nebulized salbutamol can be used. Also, glucocorticoids, steroids can be given if patient has significant bronchospasm despite after administering epinephrine to those patients. How will you prevent a reoccurrence? When the patient has recovered from this condition, I want to explain to the patient what he had, that he had anaphylaxis and is a very life-threatening condition. I want to tell him that because he has had this anaphylaxis to medication rituximab, he is also at risk of having other anaphylactic reactions to some other medication or drugs. So also I'll refer him to materials that he can read to know about the symptoms of anaphylaxis and also refer him to an allergist. I want to stop the medication he's receiving, which is rituximab, and other medications like etanercept can be used in his management. I also want to prescribe epinephrine auto-injectors for him, tell him to learn how to take it, teach his relatives around, so in case he ever had any other anaphylactic reaction, he can use it. And also pre-medication will be used for management of other medications that are also at risk of giving anaphylaxis, where I'll have to give things like steroids before administration of the medication and IV fluid and also antihistamines. Just a brief recap on anaphylaxis. Anaphylaxis is an acute, potentially fatal multi-organ system hypersensitivity reaction, which is caused by the release of chemical mediators from mast cells and basophils. It's a medical emergency and it requires immediate recognition and intervention. The word before, it said that traditionally the nomenclature anaphylaxis referred to a reaction that were mediated by IgE, and anaphylactoid reactions were those mediated by non-IgE. However, the recent definition doesn't use this again. The World Allergy Organization has reclassified anaphylaxis into immunologic and non-immunologic. For the immunologic anaphylaxis, it's when it implicates IgE and non-IgE mediated, IgG and immune complement mediated, while the non-immunologic is when there is absence of immunoglobulin, when it's just mast cells and basophil degranulation causing it. In 2006, there's a diagnostic criteria for anaphylaxis has been published. However, there's been a review in 2020 about the diagnosis. So to make a diagnosis of anaphylaxis, there is actually a table that will show that can help. So to make a diagnosis of anaphylaxis, the patient should actually fulfill one of the following criteria. So there are actually 3 criteria. The first criteria is if patient has an acute onset of illness, usually within minutes to several hours, and involves the skin or mucosal tissue. And in addition to that, patient has a respiratory compromise, like has dyspnea or wheezing, or also has reduced blood pressure or associated symptoms of end organ dysfunction. So if patient has acute onset of anything acute onset that involves the skin or mucosal tissue, in addition to one that has been listed as respiratory or reduced blood pressure. Another diagnosis can be made when patient has 2 or more of the following. If the patient has an exposure to a likely allergen. So if patient has involvement of the skin, has respiratory compromise, reduced blood pressure and GIT symptoms, any 2 of the following with a history of being exposed to a likely allergen, you can make a diagnosis of anaphylaxis. Also, if the patient is exposed to an already known allergen to that patient and therefore develops reduced blood pressure after this episode, you can make a diagnosis of anaphylaxis. These are the symptoms and signs as earlier listed. In severity, anaphylaxis is unpredictable. For some people, it may be mild. For some people, it may be severe and progress into minutes to respiratory compromise and also lead to death. At the onset of an anaphylactic episode, it's not possible to predict whether this person's own will resolve completely or if it's going to last a longer time. So administration of epinephrine is very important as it's a life-threatening manifestation. It helps. There are different temporal patterns to anaphylaxis. We have the uniphasic, which is the most common, where patients are exposed to an allergen and the symptoms peak within minutes to hours and resolves either spontaneously from the body producing endogenous epinephrine or with treatments. And when it resolves, it has resolved. We have the biphasic anaphylaxis, where patient develops symptoms within 1 to 48 hours. However, the patient gets better, but however, there's a reoccurrence of symptoms still meeting this anaphylactic diagnosis after about 1 to 48 hours after the initial resolution of symptoms. And we have the protracted anaphylaxis, where there is persistent anaphylactic reaction lasting hours to days without clearly resolving completely. Investigations, anaphylaxis is primarily a clinical diagnosis. Lab studies are not usually required and are rarely helpful. However, you can actually do investigations if diagnosis is unclear or you want to rule out any other thing that looks like it. It's critical to obtain blood samples at the time that this is happening because most of these investigations, most of these things you check out for actually elevate and disappear within 24 hours. So you can check for plasma histamine. It rises within 10 minutes and falls within 30 minutes. You can also look out for the metabolites of of the histamine. You can do it in the urine, but it's also noted that it's not dependable. It can be affected by diet. Serum tryptase measurements can also be done, and skin testing can be done to help determine when you're not sure what caused an anaphylactic reaction. For the management, as I already earlier stated, cornerstone is stop whatever that is causing it. IM epinephrine, oxygen, and resuscitation with volumes. I've described airway management, IV. It's important to note that the preferred infusion is normal saline. But however, if you're going to give large volumes after the first 2 liters, Ringer's lactate might be preferred for larger volumes of fluid. This is pharmacologic therapy. For pharmacologic therapy, the preferred medication is epinephrine. IM dosing is usually 0.01 milligram per kg, and maximum dose should not exceed 0.5 milligrams. Important to note, the easiest way to calculate it is if someone is less than 50 kg, you can use 0.3 milligram. And if patient is more than 50 kg, you use 0.3 if less than 50 and 0.5 if more than 50. And the preferred one to use is the 1 in 1,000 dilution. If it's 1 in 1,000 dilution, it usually comes in 1 milligram per ml. And it says that most times now you don't see them label the bottles 1 in 1,000 dilution, but it usually comes in 1 milligram per ml. So you can use a 1 ml syringe and take just 0.5 ml, and that is 0.5 milligram. It's preferable to inject it at the mid-outer thigh, and the IM route is preferred. Subcutaneous the subcutaneous route is not preferred, and the IV is also not preferred because IV could have at risk of Patient is at risk of having cardiovascular complications, except after the first 2 or 3 doses, and patient is not responding. At that point, you can give IV, you can do an IV fluid, you can add it in IV fluid, 1 liter of normal saline, and titrate it over time. These are other adjunctive medications that can be used. Important errors in treatment of anaphylaxis include failure to administer epinephrine promptly and delay in the injection, and over-reliance on antihistamines, salbutamol, and glucocorticoids. For follow-up care, to reduce the risk of recurrence, patients who are successfully treated for anaphylaxis should be cancelled and referred to an allergist. A mnemonic SAFE has been developed to help remind clinicians of the 4 basic action steps for patients who have had anaphylaxis. So these steps include: number 1, they should seek support, refer them to things to read about anaphylaxis, and also refer them to an allergist. They should identify the allergen identification, and they should avoid whatever that has caused it. Follow up for specialty care, give epinephrine for emergencies, also give them a bracelet, an allergen bracelet, in case it happens where they are and people are not aware. Thank you very much.
Thank you so much, Dr. Onye, for that lucid presentation. Thank you so much. Okay, so now we'll take comments and questions from our participants first. Then let's keep the thanks coming on the chat. Okay, so Dr. Mustafa is saying, thank you for the presentation. PPI prophylaxis should also be given, I think, during the pre-medication. Okay, so you take notes, Dr. Onye.
Thank you.
Dr. Ifeoma is saying thank you. Dr. Olaito Abimbola is saying thank you for the beautiful presentation. For investigation, is serum IgE and eosinophils level necessary?
Okay, thank you. No, I don't think it's necessary. I didn't see anywhere. It's not necessary. It's actually an emergency and it's clinically diagnosed. So there is no reason to start checking for IgE and IgE levels. No, I don't think so.
Okay. Dr. Anthony is saying thank you for the wonderful presentation. Dr. Mbapita, Dr. Amadi Ilomba is saying thank you for the presentation. Dr. Regina Eke says thank you for the presentation. Please, what is refractory anaphylaxis?
Okay, refractory anaphylaxis is actually when you have, treated the patient and, am I very sure? 1 minute, please. I can't recall. Okay, so refractory anaphylaxis is when there is persistence of symptoms despite administering epinephrine doses for up to 2 or 3 doses, and patient needs to have IV epinephrine infusion commenced. That is when you say the patient has refractory anaphylaxis.
Okay. How is it different from protracted?
For protracted anaphylaxis, the patient has anaphylactic reaction that has lasted hours, and there is actually no, thinking now, it sounds almost the same, but I think in protracted anaphylaxis, I don't know if medication has been given, but I know this is noted that once you're giving medication for up to 2 or 3 doses, and the patient is still symptomatic and requires that you commence an IV infusion of epinephrine, it shows that it's refractory. In protracted, I think it doesn't recover completely, lasts more than 24 hours. So they look almost alike. I'm not very sure of how to differentiate it at this point. Please, I need help. Thank you.
All right, thank you so much. Thank you. Okay, so Dr. Okorafor says thank you. Dr. Folobi Michael says thank you for the presentation. Dr. Adebimpe says thank you for the lucid presentation. In addition, there is no need to discontinue rituximab. Subsequent doses should be given slowly and to pre-medicate with antihistamine and corticosteroids. Okay, she's saying there may be no need to withdraw the rituximab. You said withdraw the drug. Do you want to comment on that?
No, actually, I didn't see anywhere they said discontinue, but it said that because I was reading about the anaphylaxis, and it said that if you have that, actually the patient should be you should not, it's not advised to continue the patient on something that has already caused an anaphylactic reaction. But if possible, thinking about it now, if you pre-medicate the patient, maybe give slowly, watch out for possibilities of having another attack. If there is none, maybe continue. But if the patient has another episode, I was thinking maybe you could comment on other medications that can be used for rheumatoid arthritis, like other metanacept. I'm not very sure, so I don't know what the practice is, whether you should stop or continue. But I would think you could continue if you give pre-medication, because part of the ways to prevent another episode from happening is you could give pre-medications and give slowly. Okay.
All right, thank you so much. Okay, I want to react to
Nkele,
that.
we have hands up. Let's listen to those
Okay.
guys first. Oh, continue here.
Okay. Dr. Temitope, please go ahead.
Good morning, teachers and colleagues and present. Thank you very much, Dr. Onye, for the very lucid presentation. So I just wanted to emphasize to contribute regarding the follow-up care for the patient that had anaphylaxis. Allergologists may not be readily available, especially in our practice setting. So some of the practical things that are related to the question. So for any agent, whether it's a drug or food that an individual has had an anaphylactic reaction to, is usually advisable not to ever expose that person to the substance. And part of the follow-up care is to counsel the patient about the dangers of the re-exposure to this substance. If possible, help the patient arrange to have a medic alert bracelet or card that states that they are allergic or they've had an anaphylactic reaction to that substance, and also to counsel the patient on recognition and self-management of the subsequent episode. So any individual that's had anaphylaxis to something, you can't be sure whether it's immune or non-immune. And if the individuals are immune, I mean, it's genetic, so they may have anaphylaxis to something else when they are re-exposed. So it's important to teach them about recognition. So the three main domains of anaphylaxis symptoms include the skin and mucous membranes, the respiratory tract, the GI system, which usually can present with severe abdominal pain and diarrhea, and then hypotension. So the patient is counseled on these manifestations and then taught how to self-inject themselves with adrenaline. And the preferred preparation is actually the epinephrine pen, EpiPen, which is designed in a way where the patient doesn't have to withdraw anything, and just a little bit of pressure on the anterolateral thigh. The needle is initially buried, and then with some pressure, and then when there are some dummies that the patient can use to practice on how to self-inject the EpiPen. But in a low-resource setting like ours, we've had some patients, and what we're taught to do, because the EpiPen is really expensive and not readily available, is our regular IV adrenaline 1 in 1,000. Usually there's 1 ml in the vial, like you said. So you get 2 ml syringes, and then you withdraw 0.5 ml. So that's 2 syringes, and they ask the patient to get something, maybe like a phone glasses case to keep it inside, and then always have it handy. And so they are shown. So we prefer the 2 ml syringe rather than the insulin syringe, because the 2 ml syringe has a longer needle, because you want the patient is going to inject it into the thigh, which is a big muscle. So you need a needle that will penetrate, that you're sure will penetrate into the muscle. And then just recently, I think just this month, the FDA approved an inhaled a nasal spray for epinephrine. It's called Neffy, which is also designed to manage anaphylaxis. And it's welcome because it doesn't involve pain, and then the patient just sprays into the nose when they're having an allergic reaction. Thank you.
Wow, thank you so much, Dr. Temitope, for that beautiful contribution. And Dr. Adebipe, I think I want to agree with Dr. Temi. I think the general advice is, if a patient has reacted to a drug or whatever substances, but advised to not expose that patient to that drug again, except you don't have an alternative. That's where the pre-medication now comes in. So if it's rituximab, if you have an alternative, you should use the alternative. But if you don't have an alternative and the reaction was not severe, then you can pre-medicate and go ahead with your infusion, or maybe reduce the infusion rate. But if you have an alternative, it's best to avoid that drug entirely. I think that's my opinion. So I agree with the Temitope. Okay, Dr. Korafo, please go ahead.
Good morning, everyone. Thank you, Dr. Onije, for the very beautiful presentation. My contribution is on how long to keep the patient in the hospital before discharge. That is, when do you discharge a patient that you've managed for anaphylaxis or anaphylactic reaction? Now, there's a guideline to that, which the guide is based on the number of doses of epinephrine that have been given to the patient on admission. So it is said that if a patient you've managed for this condition, you've only used 1 dose of epinephrine, okay, to manage the patient should be observed in the hospital for at least 2 hours or more. So it's not a case of giving the patient is fine, the patient goes home. And that is instructive because of the phases or the types of anaphylactic reactions that was just talked about. There's a uniphasic, there's a biphasic. So you want to keep the patient and watch in case the patient has another phase. So if you use only 1 dose of epinephrine, so you should keep the patient for at least 2 hours or more. If you've used 2 doses, the patient should be under your watch for at least 6 hours or more. But if you have to use 3 doses, then that patient should be in the hospital for more than 24 hours before you consider discharging after recovery. Thank you very much.
Oh, thank you so much, Dr. Korafo. Dr. Ede, please go ahead.
Thank you very much. Thank you so much. Just with regards to the protracted and refractory, it's just like you said, like Dr. Okorofo explained, if it lasts beyond 24 hours, that means patient has to be on admission and observed. But then you don't expect that emergency to last more than 4 hours. So that's why some people believe for protracted, if it lasts longer than 4 hours, then you can say it's protracted, whether the patient has started the treatment or otherwise. I think that's just the difference.
All right, thank you so much. Okay, we still have a lot of comments on the chat. I don't know if I can go through them. Can I go through them? We still have a lot.
Let's focus on the questions and comment, not on thanks, because of time. So I'll finish before 8.
Okay, no
Thank
problem. No problem. Okay, so Dr. Anthony and Dr. Justice are saying, please, can you differentiate between anaphylaxis and angioedema?
Okay, thank you. For angioedema, it involves swelling of mucosal tissues. That's maybe swelling of the tongue, uvula, but there is actually no systemic involvement. That is, the blood pressure, for example, is not affected. But for anaphylaxis, there is usually involvement of there's actually systemic involvement, most times with affectation of either blood pressure, showing of end organ perfusion that is not enough for the end organs, like cold extremities. So for angioedema, it's just like a symptom where there is involvement of the mucosal areas, swellings, but does not involve the system. There's no systemic involvement. But anaphylaxis has systemic involvement in addition to other symptoms. Thank you.
All right, thank you so much. Dr. Cyril has a lot of questions. He says, why do you have to give the oxygen at a flow rate of 15 liters per minute? You're not treating
okay, so basically the idea.
Okay, go ahead.
Actually, the 15 liters was what I saw in research in all texts that I had read, where I got my reference is like, but I think some places said high flow oxygen. So just basically to help with oxygen delivery to organs. I don't think there is any particular thing about why is it 15. I'm not sure exactly why it's 15, but 15 is what I saw in text. But is commence oxygen high flow oxygen so that it helps in patient's care. I'm not sure why it's 15 liters exactly, but sorry.
All right, thank you so much. So it says, what's the relationship between anaphylaxis and angioneuritic reaction?
The relationship between, I'm not sure. Sorry, can you just ask again? Sorry.
Okay, he's saying, lastly, what's the
Relationship
relationship
between
anaphylaxis, going by your definition, and angioneuritic reaction? Isn't that what you just explained?
Yes, I think it's the same thing. That's why I'm confused about the question.
Okay, so Dr. Atta says, thank you very much for a lucid presentation. Refractory anaphylaxis occurs when a patient has had 2 IM injections but no improvement of symptoms like the circulatory or pulmonary symptoms. Then protracted anaphylaxis occurs when patient responds to initial dose of adrenaline, but symptoms is still persistent without full recovery. Both is still treated with adrenaline and other adjunctive medications. Thank you so much, Dr. Okute. Thank you, Dr. Momodu, Dr. Cyril, and others who have contributed. Thank you so much. Okay, so I'll hand over to our teachers. Margaret Saville.
Oh, thank you so much, Dr. Nye. I know her personally, wonderful lady, very intelligent. So you want to appeal to you. Let's appeal to that beautiful Dr. Temi. Please be moving your stuff. Let's share your wealth of knowledge and experience. So thank you so much. It was a wonderful presentation. The commenters, thank you. I appreciate you. Dr. Chitu, I want to make my comment. I don't want to be online when I make that comment. So Chief Chitu, Koke, I started Prof. Oladimeji. Prof, good morning, sir. Dr. Success, Dahatu, Ajibola, Okopi, Fatima, Chief Remigos. Any comments, please?
Thank you, Dr. Christabel. I don't know. I wanted to. I don't know if she tried to differentiate between anaphylaxis and angioedema. I think I had someone ask the question. I don't know if she did. Okay, so what's the difference?
Okay, so I said in anaphylaxis, it actually involves there's a systemic involvement of both when there is angioedema and other symptoms, but there is actually systemic involvement like respiratory involved or cardiovascular where there's hypotension. But in angioedema, it just involves swelling of subcutaneous tissues without any systemic involvement. So where there's things like urticaria, swelling of the tongue, lips, uvula, but no systemic involvement.
Okay, yes, okay. That's a very, very good way to differentiate it. And I think that's just what I wanted to clarify. Thank you.
So thank you, sir. Thank you. Any comment from our teachers?